I'm Dr. Ariel Polanca, and you're watching The Step. Welcome to The Step, Dr. Creech.
Thank you. Thanks for having me.
Absolutely. So, we have you on the podcast today, and this is going to be a little bit kind of sports focused
Okay.
because you yourself were an athlete. So, I was hoping that you could kind of talk to us a little bit about your athletic career.
Sure. Yeah. I started probably soccer was really kind of what I ended up focusing in on, and I was a little bit later in life to start that. I mean, nowadays, like you see kids that are doing like year-long soccer at like 7 years old, and I started kind of midway through middle school, and then by the time I got to high school, I was pretty serious about it. We were playing kind of club soccer and those kinds of things. And then I was lucky enough to be able to have played at the University of South Carolina, which was a huge dream of mine. I grew up in Columbia, South Carolina. My whole family went to the University of South Carolina. I wanted to play soccer there before they even had a women's team. So, I remember when they started a women's team there. I was at one of their first soccer camps, and so kind of a really big dream of mine to go there and to play soccer there. And so that it was a huge step for me. I was initially a walk on there. I was too slow and too fat, which is a terrible thing to tell a 17, 18-year-old girl, but those were the realities back in the day. And so, I mean, it really took a level of commitment for me for fitness to really kind of get there. And they gave me a shot. And then my sophomore year, I was able to earn scholarship money. So it was sort of a Cinderella story a little bit for me. And that's kind of where it started and ended, I suppose.
That is quite a work ethic to go
Yeah,
from that to get scholarship. Wow, that's
yeah.
incredible. So, what position did you play?
I started off as a forward early on, and then kind of really found my role, I guess, more as a center midfielder. I was much more sort of focused on distributing, and I would say that my strong suit was much more with the ball at my feet than running off of it. Some of the athleticism of those girls is just incredible. And then eventually, after some of my injuries, I was dropped back a little bit further where speed didn't matter because all that stuff you lose a step here and there. So
You
I
lose
think
a step.
yeah, but and then no pun intended.
I love it.
By the time I was done with it, I was more of like a center stopper role.
Well, you gave my segue for me, so I thank you for that so much. But and we had talked about this. So you suffered some pretty significant injuries through soccer. Can you talk about those?
Yeah, yeah. Initially, the summer after my freshman year, I had a Jones fracture of my right foot. It's so interesting to go back and look at that part of my life with the lens of what I know today. And I was 18, and I was treated conservatively initially. I spent about 3.5 to 4 months in a cast, did not heal, then went on to surgery, which was not an intramedullary screw. It was a quarter tubular plate and a bone graft from my distal tibia. It healed fine, but I think looking again back at where we are now in foot and ankle, particularly with Jones fractures in young female athletes, you kind of cringe. But nonetheless, it healed fine, and I came back the following summer. So about a year and a half after, I had a unhappy triad, so ACL, MCL, meniscus on my left knee. That was pretty devastating. The Jones fracture was kind of one of those things that hurt when it happened, and then it really was just more of the recovery and the immobilization. But the knee was really tough. It was a very long recovery and very big surgery and those kinds of things. So there was a point of my life where my parents, I think in my mid 20s, kind of looked at each other and said, "We've been a year with no surgery." So they were pretty big events in a young person's life, which I think again, kind of looking at things from the lens of what I know today is something that we probably don't pay enough attention to, particularly in our young patients.
We will have some listeners who won't know what a Jones fracture is. Can you talk to us about what a Jones fracture is?
Sure. Yeah, it's a fifth metatarsal fracture. at a particular place where the blood supply, the nutrient artery of the fifth metatarsal is disrupted, really just by the fracture pattern alone. And so it is notorious for delayed and non-healing. These days, we are pretty aggressive with them, particularly in athletes and female athletes, because there is a higher propensity for non-union or not healing in those patients, and can really offer them surgical intervention very quickly. Some patients opt for a conservative approach and is still very appropriate. But at that point, I think we these days pay a lot more attention to overall metabolic health with vitamin D supplementation and those kinds of things. And again, kind of looking at that point of my life with the lens of today is very interesting to see how far we've come in 20 years. Yeah,
Yeah, I think it's safe to say that if, you were to treat yourself right now and the similar patient came to you, that patient would have been offered a intermedullary screw and some vitamin D pretty much right off the bat and
for
would have
sure.
been returned to sport a lot quicker.
Yeah, for sure.
Do you feel like you fully rehabbed from your Jones fracture? Did you feel like you got back to the same level of play that you were at before?
Yeah, and I think, it's funny even just kind of thinking about this talk and having a right foot injury and then subsequently a left knee injury, you kind of wonder if that is true. It probably certainly coincidental, right? You have one side that is injured and then rehabs. And I think again, particularly for female athletes, we've known for so long, or at least speculated about Q angles and menstrual cycles and hormonal things with knee injuries. And even now, I just Sue Bird and uh, her name is escaping me now, but there's another soccer player that have a podcast, and they were talking about this massive study that's being undertaken in the UK about relating ACL tears, particularly to menstrual cycles and hormonal fluctuations in females. And you think, man, people were talking about this 20 years ago. Why are we just now getting to that?
Yeah.
So yeah, I mean, it's an interesting thing to look back at and say, I don't know that I felt like I had. I remember feeling like I was in very good shape, and even it being so much more heartbreaking because I felt like physically I probably was more prepared to play college soccer than I'd ever been in my life. But you do wonder, that's probably not a coincidence for a contralateral leg injury the following year.
Yeah. Now, did you know that you wanted to be a surgeon before college, or do you feel like either A, being a collegiate athlete, or B, going through these injuries sort of led you into that career path?
Yeah, I had no idea. I definitely was always very sports focused, and I remember at one point really wanting to be a sports psychologist, probably not having any understanding of what that really entailed. And I think, like most young people, I went to college with a vague idea of things that I thought I wanted to do, but definitely it was being in a large Division 1 athletic training room, and this is probably total HIPAA violations these days, but they would sit you with like 18 other kids and you're just sitting there. And again, I was a huge Carolina fan even then. And now these people that my dad and I are watching play football, they're my friends and my classmates. And so we're all just kind of sitting, and they would have these doctors that would say, oh, Corinne is here for Jones fracture follow up, and they would round with their fellows and those kinds of things. But your rounding was like the training table next to you, right? So you would see all of these things that people were going through. There was a kid from the men's team who also had a Jones fracture. Somewhat not
Did
ironically, he went on to
did you
be
guys high five?
yeah, yeah. Well, it was very like, everything was competitive. It's like, how much bone healing did you have today? Are you being advanced? And I'm going, no, but yeah, so it was, and they were very gracious. I think once they kind of figured out that I was interested, they always let me kind of tag along. And I went and kind of scrubbed into some cases with them and observed some things, which again, probably these days is totally not allowed. But it was great. And I think really, truly, I think is 1,000% why I do what I do today.
That's cool.
Yeah.
Do you think your experience as an athlete, influences the way you treat athletes?
Sure, I do, and I always have to kinda check myself a little bit, particularly with a Jones fracture patient, to not treat the 18-year-old version of myself, right? And to give patients information so that they can make an appropriate decision for themselves and those kinds of things. And I think for sure, even in motivating myself and, I'm lucky enough to be involved with a residency program and motivating those kids and how we teach and instruct. I think all of that, there's no way to undo, or that's so woven into our personalities and our makeups as people. I think it makes a huge difference on the way that I treat everyone and listen. I remember um wanting so much to tell my story. Like, they knew I had heard a pop, they had seen the MRI, they knew what my prognosis was, they knew what they were going to offer me. There's so much of a patient story that, to diagnose something like an ACL tear or Jones fracture, we don't necessarily need to hear. We kind of already know what's going to happen with these patients or what we're going to offer. But I do think that that for me was so important to have that. And so I do think that as a physician, it's really important for me to listen to patients and hear them, even if it's not necessarily going to make a difference in their diagnosis or what our treatment plan is going to be. I think it gives you a big insight, and then initially just kind of helps you establish that trust environment.
It sounds like you got back 100% after the Jones fracture. It sounds like you did not get back 100% after the unhappy triad. Is that correct? Is
Yeah,
that
and I
fair?
think, yeah, that's fair to say. And I think, to be even more fair, in case some of my teammates from back in the day hear me, I think it was also just a big reality check of, I'm a sophomore in college, going into my junior year, and what's next for me? Like, am I going to play professional soccer? I mean, really, women's professional soccer in the United States was really pushed forward after the '99 World Cup with Brandy Chastain and the moment, the penalty kick win. So there was, I had graduated high school in 1999. So that was really just pushing forward. So I knew that this was kind of it for me. So it was also, I think, having that sort of separation from the sport that every athlete, I think particularly a lot of college athletes have to have, where you say, this was such a huge part of my life that now I know that it's really like, I'm not going to go on really anywhere with this from a professional standpoint. So what is next for me? And I think I really started to focus a lot more on academics and those kinds of things. I still played and was still very much involved, but I think it also, at that point, you really kind of are starting to figure out what the I wanted to be able to live and run and be active. I was very uninterested in going through that a third time. So, but yeah, I mean, I think for a variety of reasons, it was not something that I was not majoring in soccer anymore at that point.
Yeah. You didn't want the 3rd time to be the charm. No.
I had a teammate and a good friend growing up who, I think at that point, she ended up having 4 ACL tears, like 2 on each side, which is just horrific. And her father was an orthopedic surgeon, and her mother would beg for her to stop playing. And, I remember the funny conversations between them where she'd say, "What about swimming?" And her dad would say, "No, that's terrible on the shoulder. She's got bad joints," and kind of chuckled about that. And ultimately, we both came to a point where we were saying, I don't know, is this it? Like, do I really want to keep doing this? It's such a huge time commitment. It's a huge physical commitment. And he said, don't quit, because no matter what you do for the rest of your life, someone is always going to want to talk to you about this experience. And it really is true. I think people maybe give me a little bit more credit for, and maybe 20 years later I can give myself a little bit more of a an ego about it. But it does help me relate so much to people, and I think people are so interested in that college experience because it is such a great one. It's such a unique thing to go through and those kinds of things. So I'm glad I stuck with it and was able to finish it. But I think, again, it just gives you that perspective of where you're going to ultimately go with that.
I think we all have those patients. We have the patient we need to push a little bit, that we need to give that confidence that, like, "No, you're okay. You're healing okay. You can trust this. You can go." And then we have that athlete that we have to say, "Ooh, if you go too fast and if you push this too much, you're gonna hurt this. You're gonna injure yourself and you're not gonna heal." How do you balance that? Like, do you have, like, an algorithm, or do you have, like, a quote or a saying or a little, like, mantra that you give your patients? Like, what's your balance with that?
Yeah, I think that's a great question, and I think there again kind of goes back to listening to the patient and really developing a relationship and figuring out which of those patients you're dealing with. What's the personality behind that? And I think being able to share some of my story for those patients who are hesitant. I remember the first time I could run after the Jones fracture was healed. They cut on the lights, and I think we had practice. So I don't think they cut the lights on just for me, but I was running down the field, and the South Carolina soccer stadium is called the Graveyard because it's right next to a very tiny historic graveyard in Columbia. And so, just such a moment, right? You're under the lights, and I ran all the way down the field, and then I walked back crying because I because I said this is never going to be the same. And it was fine. But I distinctly remember that point. I think I share that with a lot of patients who say, I don't know how I'm going to do this. I don't like this is never going to be the same. And being able to say, well, you just are going to have to learn to trust it. And that's why we're taking X-rays and looking at this together. And then you're right, the patient that comes in, post Achilles repair that's not wearing their boot after 2 weeks, and you're going, great. When did we make that decision? So um, I think being able to be stern with those patients and say, here's what we know. You've invested so much time and energy in this and money to some degree. You've really got to let me guide you and let your physical therapist guide you. I'll often kind of print out patient protocols for them as well as the physical therapy ones so that they know kind of what they're getting into and those kinds of things. So I think it's a great question. That there's a massive shift between those two patients, and really laying down the law in either scenario can be really essential and critical to their recovery ultimately.
Yeah, I find that, I find, I treat patients like my friends, I treat patients like my family,
Sure.
except sort of in those 2 scenarios. I
Yeah.
think it's sometimes a little tough love is needed and necessary, because ultimately, why are we here? For good patient outcomes. So if you need a little bit of that tough love to get a good patient outcome, I find in those 2 scenarios, sometimes they need it a little bit. It sounds like pretty similar for you too.
Absolutely. Yeah. And I think
Yeah.
when you have a good relationship with them and, you've been kind and hugs and smiles, and then when you lay down the law, I think it's maybe the juxtaposition of that. They listen a little bit better, but yeah, for sure.
Totally. Now, you and I had talked about this a little bit, and this was kind of a ongoing thing at like Stanford too that we would talk about when I was there. That we felt like athletes would make better residents, or residents that had kind of an athletic background just seemed to thrive a little bit better, at least in the beginning of residency. Can you expand on that a little bit, or why you would think that might be the case?
Yeah, I think, with anything, particularly with athletics, not everything goes smoothly from day one. We've all had a point in our life, particularly in athletics, in the high school scenario. Most people are doing very well who are going to go on to that next level. And then typically, like for me, I got to college and everybody's the best player in their high school, in their state, in their city. And I think that really understanding, particularly during the training process for residency, is that you're going to be bad at a lot more things than you're going to be good at initially. That's why you're in a residency. And I have this conversation. I've had this conversation with my incoming and rising chiefs now. Is that that's the whole point of this. You have to get uncomfortable. You have to be comfortable with being uncomfortable and hearing and understanding correction and being able to make those things. I do think that athletes tend, and I think I understand how to motivate them a little bit better, but I also think it's such a generational thing, and it makes me feel very old to say that. But I think having to sort of step back and say the fire and brimstone that really pushed me is not necessarily the way that every resident is going to respond. Um, I went through two coaching scenarios when I was in college, and one woman, you would run through a brick wall for her. I mean, she was such a motivator, and everything was heaven and hell, fire and water. I mean, there was no gray area for her. And then I played for a husband and wife who are still at the university, Jamie and Shelley Smith, and they were just very business about everything. I remember when we would get in trouble, or someone on the team would not show up to practice or be late or what have you, we would run as a punishment. And Jamie and Shelley would say, you're running because you're a college soccer player. There is running involved. Don't make this a dramatic thing. You're not in trouble. Nobody hates you. We are doing this because you have to be in shape to play. And so I have that conversation with, interns where this is not fun. Intern year is not fun for anyone. But this is the first step of understanding how to manage patients, and it's critical in your development. So I think being able to take out some of the drama of that, but then also to give back some of that sort of, you've got to really, motivate some of these people, and we all need motivating in some sense. So I think also the physical awareness, the body awareness that some athletes have, understanding where you are in space, utilizing both extremities at the same time, high hand-eye coordination. Those are all things that I think from an athletic perspective, they're a little bit further along with that sometimes than non-athletes.
Absolutely. I think you summed that up really nicely. How do how do you deal with the patient with unrealistic expectations? My true story, and like one of my patient examples, is that I had a patient who was an ultra marathon runner. So he ran 100-mile races, and on mile 88, his right calf muscle started to become slightly sore. And he was in my office, and he wanted me to make that better. So as a case point, we also have can we have an aging population? So we have someone that was an athletic person and who might just happen to be getting older and wants to maintain that degree of athleticism. What is your approach to managing unrealistic expectations in an athletic patient?
That's a great and tough question. Yeah, and I think it really is. I think again, hearing the patient and letting them sort of speak to what they want, and asking what are our goals here, because I can't make mile 89, like I don't know that I can get that much better, right? Without some true pathologic being. I think some of those patients need to see imaging and go through that with a fine tooth comb, and to say, here are things that, maybe from a physical therapy standpoint, we can get you better, but you have to realize that at mile 88 of an 100-mile race, things are going to start to sort of fall apart. The flip side of that, I think, is for some patients who have had devastating injuries, or, like in my Charcot population of, well, I need to be able to walk and exercise for my blood sugar and weight management, and saying, here's the reality of this situation. We are now looking at a limb salvage situation per se, not getting you back onto the track, which is really not where we were starting off from anyway. So, I think it is hearing them, hearing what their goals are, and then being able to sort of say what that would take to make that better. And if I can really do that. I do try to end every visit, particularly my surgical patients, with a conversation of, what are you not doing right now that you really want to be able to do? Because I do think that there are some instances where we can modify that activity or give a realistic time frame. And I think it's also our jobs to say that, particularly in the surgical conversation from the get go, so that we can say, now, we talked about this. You are going to not be running for 3 months. We are waiting on this bone to heal and this sort of ligamentous complex to heal. And you have to be able to do this at physical therapy well before you can advance to the next step. And I do think when you break it down like that, and also just let them vent, that most people kind of come around.
I think that's great. It's all about managing expectations. And one of my best mentors said the definition or the difference between an explanation and an excuse is timing. And if you talked about all of it in the beginning, then it's an explanation. If you talk about it afterwards, it starts sounding like an excuse. So I love that. What are we trying to get you back to? And if you talk about that, and I think that's really reasonable. My one of my big pet peeves is that now patients get their MRI results before coming to see you. And they're gonna see, this effusion and this bony contusion and my ATFL is ruptured and how do you manage that? Like how do you manage the balancing the we don't treat an MRI. This is just a radiologist reading this. We need to correlate this with you. What's your just kind of your paradigm with that?
Yeah, I think that that's a great point. I think it's the CARES Act where you get all of that information. And it's, I think patients need to have ownership of that material. But you're right, it's tough when you haven't even had a chance to see it and they've sent the patient question of, what does all this mean and those kinds of things. So I think from the get-go, I usually tell patients what I'm looking for with the MRI. And then I'll send a message with their MRI results attached to say, hey, let's set up a time to get together. I try to do a lot of that via video. Post COVID, we've got such great resources to do that so that they can see on their computer screen. And I will go through each thing point by point. What does this mean? Where is this? Why is this important or not important? And then also, I think having a good exam, particularly if you're doing a video visit, you've got to go back and say, hey, you know, you have the dreaded perineal tear on an MRI that wasn't appropriately done under an ankle proto. You didn't even have any pain in this vicinity. Here's where that is. Here's where your pain is, and I try to hit head that off by hitting all of those points so they don't feel like we're missing anything and sort of sweeping anything under the rug. But again, I think to your point, setting an expectation of here's why I'm getting an MRI, here's why I'm getting a CT scan, here's where your pain is, here are the things that we're going to help. We're going to use that material to now help guide our treatment plan. Because when we come back to it, they kind of have a little bit of understanding of, oh, my pain is on the outside of my leg. This structure she's showing me is on the inside of my leg. Maybe those two things don't correlate.
I selfishly just asked you that question because I was really personally asking for advice. So thank you. Says I think I think
No,
I'm gonna
of course.
I think I'm absolutely gonna use that. So
Yeah.
I I really appreciate your approach. I mean, it's so apparent that the way you treat patients is talking to them and asking them, "What are you lacking and what are you looking for here?" And I really think that's probably why you are a wonderful doctor and a wonderful surgeon. And I just really appreciate you spending time with us today.
Oh, thank you. That's lovely of you to say. I know that that is the same for you. I think we all have this huge obligation to our patients to hear them and to treat them. And so much of the human experience is understanding where, or trying to at least understand where people are coming from. And that sometimes is a tough thing to do at the 30th patient of the day when you're exhausted and have your life. But that's what we've been sort of tasked to do. And even I need a reminder to do that. I especially need a reminder to do that. They're taking time and effort and money to come see us and trusting us with this huge part of their life, even though it's the 49th something or another that we've seen that day. And I think it's easier to talk about sometimes than it is to implicate or implement rather. But it's why we're here. So, but thank you so much for having me. I really
Eh,
appreciate the conversation.
Hey, this was a good reminder for all of us. So thank you.
Yeah, you got
And
it. Back at you.
to all of our listeners and viewers, thank you so much for being here today. And we look forward to the next time.